Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. Today is 3rd of June, our third day of full lockdown during MCO. I'm going to share with you another interesting topic, what we call as pulsatile abdomen. Okay, pulsatile abdomen. Okay, so it's not uncommon in surgery. You can encounter patient with acute abdomen. Acute abdomen means sudden onset of abdominal pain. So there are many differential diagnoses of acute abdomen, right from the peritonitis, anything in the abdomen. You can have pancreatitis, acute appendicitis, cholecystitis, ischemic bowel, even the very rare uncommon presentation of myocardial infarction also can come with acute abdomen. But there is one condition where you need to have very good high index of suspicions is Triple A. Okay, and most of the Triple A or triple abdominal aneurysm are asymptomatic, and usually they were diagnosed by incident. So, for example, they come with abdominal pain, acute renal colic, or cholecystitis, and initial finding they found that patient have dilated aneurysms, dilated abdominal aortic aneurysm. Okay, what we want to all the junior doctors must be able to pick up the sign and symptom. And when patient come to you with sudden onset of abdominal pain, usually back pain, and then after you exclude all the histories, after you get all the histories of the abdomen, and during the examination, then you will realize there will be pulsatile mass. I'm not going to teach you how you get the history and all those things. Pulsatile mass means when you lower your eye level at the level of the abdomen, you can see the mass pulsatile at the region of the umbilicus, maybe to the right, and you confirm it by palpate. During your palpation, you can feel the mass. You can feel the mass, and then when you put your hand on the abdomen, the mass is, your hand will be pulsatile, and when you examine it properly, it can be either transmitted, which is normal in patient elderly with hypertrophic wall of the aneurysm of the normal aorta. They can have transmitted pulse, or you can have expansor pulse. So these are the things, the one of the main features of diagnosing Triple A. Okay, I'm not going to go into detail to the clinical aspect, but whenever you get this kind of case, it's very important for you to go back and reclub and go deep into the history. Okay, usually presentation of abdominal aortic aneurysm is in elderly patients, and they are associated with risk factors of smoking and hypertension. These two things are important, so get that thing first. Then when you club the patients with history of abdominal pain, elderly with back pain, you must know to ask about the history of complications. We are not worried about asymptomatic Triple A. We are worried about the complication arises from Triple A. So what Triple A can progress into? Okay, by the definition, what is aneurysm itself? Aneurysm means it's a fusiform dilatations of the vessels, of the vessel involve 3 layers of the vessels, involve tunica, intima, media, and externa. So these 3 layers must involve usual form, and by definition it must include these 3 words: permanent, okay, permanent abnormal dilatation of the vessels. Abnormal permanent dilatation of the blood vessel involve these 3 layers. Okay, and if it is not involved all these 3 layers, it is called as false aneurysms. Okay, then we call it triple A when it involves below the renal branches of renal artery. Can goes along the way until the common ilia and or external ilia. So when you think this patient is having abdominal aneurysm, most of the time they don't complain. So they only complain when patient develop symptoms. One of the symptoms is pain. Why pain? Pain can be due to presence of one is because of the aneurysm itself is already dilated and can stretch the wall of the aorta. That is one reason of the pain. Normal diameter of the aorta, abdominal aorta, 3 cm. Pain also can be due to pressure of this abdominal aorta into the posterior organs. Can impinge the nerve, can impinge the ureter, can cause hydronephrosis, can impinge the pancreas, and all those things that can cause pain. Or pain in the later stage of triple A is due to leaking of the aneurysms. What else aneurysm can give rise to? So the large aneurysms, sometimes they consist of thrombus, and this thrombus can cause emboli into the distal arteries, and not uncommon, they can present with threshold. Threshold means evidence of gangrene or evidence of chronicities into the both limbs because of the emboli dispatched from the thrombus of the triple A's. And what complication they can have? Furthermore, they can have aorto, gastro or aortoenteric fistula. In this kind of cases, patient can present with either hematemesis or hematophysia. Alright. And in long standing, when the aneurysm compresses on the ureter, especially on the left side, this patient can sometimes present with renal failure, persisting or progressing increase in the blood urea and creatinine level. So you need to get all this history of complication, and rare they can become fasciculated into the inferior vena cava, and you can see dilated veins because of higher pressure of aorta fistulated into inferior vena cava. They can have aorto cava fistula. Okay, that is the history that you must include, you must get during your clerking. So must exclude all these complications. And later complication, leaking, usually patient presented with back pain, sometimes low blood pressure and pallor, because leaking of the abdominal aorta actually goes retroperitoneally, and usually abdomen is not the standard, but you can see feel like baggy things, and usually patient pale, presented with back pain, some form of raised blood urea and creatinine. When you did CT, you will found the diagnosis. And the last catastrophic incident is rupture. When aneurysm ruptured, mortality is very high. 50% of the ruptured aneurysm died at home. Another 50% died on the way or in the hospitals. Alright. So what is our role? So after you get all the history, get very good histories. And in the history must have history of smoking or hypertension. And we, the moment we diagnose, see whether patient hemodynamically stable or not. If patient well, abdomen soft, hemodynamically stable, only diagnosed just by means of CT or ultrasound, don't need to panic. You must investigate, get an ultrasound and CT. Okay, then our job is to determine which patient requires surgical intervention, which patient not require surgical intervention based on the size of the aneurysm. study showed that any aneurysm less than 4 centimeter, nothing will happen to the patient. Okay, patient yang ada aneurysm usually age 60 and above. And then aneurysm with a size of 4 to 5.5 centimeter, these are the group of they usually still safe. You just need to do ultrasound every 6 months. But the moment they cross the 5.5 centimeter magic numbers, the risk of rupture increasing. The risk of rupture increasing. The risk is increasing by 5. The enlargement is increasing by 5 millimeter to 1 centimeter a year. And these are the case that has been advised for early surgery. So 5.5 centimeter and above, we actually follow the UK small aneurysm trial, in which they have conducted like 1094 cases. They do surgery, one limb they do surgery for aneurysm size 4 to 5.5 centimeter, and another limb they perform surgery in patient with bigger aneurysm, means more than 6 centimeter. So the outcome of the study showed there is not much difference in terms of mortality for these two groups. So it has been advised any aneurysm which is less than 5.5 centimeter, you don't have to do surgery, just enough to follow up these patients. 6 monthly ultrasounds, control the hypertension, and stop smoking, because the risk of ruptures is less. Alright, the risk of rupture is less. So for any aneurysm higher than size bigger than 5.5 centimeter, you advocate for surgery, because at this time the aneurysm will enlarge at the rate of 1 centimeter a year. So you just see patient age 70, size 5.5 centimeter. When he reach 71, size becomes 6.5. When he reach 72, size becomes 7.5, 8.5, and the risk of rupture increases. Okay, so this is the reason why we suggest surgery for patient aneurysm size 5.5 centimeter and above. And another criteria is presence of thrombus. Irrespective of the size, this patient, if fit enough, should be subjected for surgery. Okay, surgery can be endovascular or open surgery. I'm not going to discuss on that, but nowadays 90% of cases they can do endovascular, which is faster, safer, and less morbidity. So what is the mortality risk of patient undergoing elective surgery? In a good center, it's about 1 to 2%. Means in a good center, you optimize the hypertension and patient stop smoking, they can perform safely. The mortality can be reduced to 1 to 2%. But if you perform during emergency, means during leaking, rupture, the mortality is as high as 50%. Alright, that is very a little bit precaution for young doctors who usually this procedure will be done at the renowned vascular center. So when we prepare the patient, when you diagnose the patient leaking or whatsoever, make sure you don't over vigorously pushing the fluids or blood into the patient, because we don't want too much volume of fluids inside the vascular system, because we don't want the leaking become worsen, we don't want the aneurysm to be ruptured. So blood pressure should be maintained at the lower side. Usually we accept systolic blood pressure 90 or maximum 100. Don't push into much fluid, because in the end all the blood will leak into the retroperitoneum and nothing much you can do. Okay, that's all about Triple A, because this is just superficial, but it's important for you to get good history, to stratify the patient. Anything less than 5.5 centimeter, conservatively 6 monthly ultrasound, stop smoking, hypertension, report to medical, do echo, see the patients, regularly. Anything 5.5 centimeter is patient fit, irrespective of the age. You can discuss for the surgery because this will benefit the patient. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.